Hello and welcome. We are excited to now break into a focused talk on the cardiac manifestations of heterotaxy syndrome. We will start with a basic review of the right and left atrial isomerism, outline the common cardiac manifestations seen in patients with heterotaxy syndrome, discuss the limitations of the current nomenclature, review how the cardiac manifestation of heterotaxy affect overall outcomes, and discuss a few specific high-risk cardiac complications we know to be associated with poor outcomes. So building on Dr. Weir's presentation, as we launch into the cardiac manifestations of heterotaxy syndrome, I want to highlight again what happens to sidedness in heterotaxy. So taking this picture of our hospital with right and left assigned as we would assign them on a chest x-ray, if you just flip the picture, you get sinus inversus. If, however, you duplicate the right side onto the left, or duplicate the left side onto the right, you get the two subtypes of heterotaxy, right isomerism and left isomerism. Fundamentally, heterotaxy is a duplication of sidedness, not inversion. But with that in mind, when trying to diagnose or classify heterotaxy, for each organ, we can ask several questions. What side of the body does it belong? Does the organ have a unique left and right side? And for our presentation, we want to specifically consider the question, what is the left and right side of the heart? How should we define? Classically, cardiac isomerism is described in terms of the morphology of the atrial, and specifically the atrial appendages. The right atrial appendage is broad-based, with pectinate muscles extending out into the atrium itself. The left atrial appendage is more narrow and finger-like, with pectinate muscles confined to the appendage. Meanwhile, in right atrial isomerism, you have bilateral, morphologically right-sided appendages, with pectinate muscles surrounding the entirety of the adjacent atrioventricular junction. In left atrial isomerism, you can see how the finger-like left atrial appendage is duplicated on the right, with pectinate muscles confined to the appendage. Now, it's all well and good to focus on the atrial appendages, as they are a useful reflection of the atrial sidedness, but they are a very small part of the heart. So let's take just a minute to examine the sidedness of normal cardiac structures so that we can view them as clues to the overall pattern. In a normal heart, the superior and inferior vena cava should be intact, returning venous blood to the right side of the heart. The pulmonary veins should all return oxygenated blood to the posteriorly located left atrium. Two separate valves should separate the atria from the ventricles on either side of the heart, while the outflow from the right and left ventricles should also be separate and coming from the appropriate side. Finally, the electrical hardware should be in its place in the right atrium with single SA and AV nodes. However, when sidedness is duplicated, all bets are off. The hepatic portion of the inferior vena cava, the right-sided structure, is typically interrupted in left isomerism. The pulmonary veins of left-sided structure often exhibit highly variable and anomalous return in right isomerism, as the right atrium has been duplicated, as it were, onto the left. The presence of the SA node and AV node in normal right atrial tissue sets up the possibility of dual AV nodes when right isomerism occurs, as well as heart block when left isomerism is the problem. But interestingly, the critical function of the heart, pumping of blood to the lungs of the body, is most drastically affected by right isomerism, which has higher rates of single ventricular heart disease, as well as abnormally located or narrowed outflow tracts or great vessels. While the laterality of multiple organs is affected, the diagnostic focus has been on the atrial and splenic anatomy. And I think that makes sense when you consider the clinical workflow and how the technology has progressed. You start with a chest x-ray, you see the heart or stomach in the wrong place, and then get an echo and an ultrasound, and the atrial appendages and splenic anatomy are the things you can see next. But with increasing utilization of cross-sectional imaging, CT and MRI, we can get more anatomical information on the lungs and abdominal organs and really hash this out. But as often happens when you get more information, it tends to confuse the issue a little bit further. So this retrospective review of cross-sectional imaging in heterotaxy patients showed that a decent number of patients just don't stay in their lane. It turns out that about 20% of the time, both right and left isomerism are seen in different organs in the same patient. The patient whose images are shown here have atrial situs solidus, bronchial right isomerism, and abdominal left isomerism. Which, returning to our example using the photo of the Children's Hospital, it looks something like this. So the take home here is that even if we diagnose clear left atrial isomerism, you have about a 20% chance of being wrong about what lies below the diaphragm. And this risk of disharmonious patterning may underlie some of the variability in anatomy. This table shown here comes from the ECHO textbook that all pediatric cardiology fellows use. It summarizes the various case series of heterotaxy patients that have been published to compare the incidence of cardiac anomalies that are seen in the asplenia and polysplenia phenotypes. It shows only one anatomical characteristic that is not shared with both groups of patients. An interrupted IVC is a very strong clue for left cardiac asymptote. For that reason, I'll take a few moments to share my understanding of why this is so. On the left, you see the primitive venous vasculature in the developing embryo. As development progresses, the complex and coordinated regression of some of these veins occurs, leading to the mature venous system you see here right. Looking back, we see a difference on the left and the right sides of these veins at the level of the liver. So if you have left isomerism, duplicate that left side, absent of onto the right, you will impair the development of some part of the hepatic or suprarenal segments, leading to an interrupted IVC. In this case, the venous drainage of the lower body has to go through azygous system shown here. And as we lean on advances in cross-sectional imaging, we can look for new ways to phenotype left and right isomerism, like this study, which has given us insight into the lymphatic drainage patterns occurred. This study included patients with right and left atrial isomerism, as well as pulmonary and abdominal sinus inversus patients with congenital heart disease. In 56 patients for whom the terminal thoracic duct was visualized, they found that the SVC and aortic arch sidedness were independently associated with terminal thoracic duct sidedness. But you can also see that left or right atrial isomerism did not seem to predict or be associated with the thoracic duct drainage anatomy. So next, we're going to switch gears and talk about the cardiac outcomes in heterotaxy.
Excellent. So for those of us who take care of patients with heterotaxy, it should come as no surprise that these patients have among the highest mortality risk of all patients with congenital heart disease. This particular Kaplan-Meier curve compared 10-year survival in patients with single ventricle heart disease at the Mayo Clinic over 5 decades. Heterotaxy is shown in dark red, and other forms of complex congenital heart disease are shown in other colors. They found an overall 10-year survival rate of 78 to 85% in patients without heterotaxy, but in patients with heterotaxy, survival was closer to 65%. But why do patients with heterotaxy do so much worse? We can start by asking, when is the highest risk period of time in these patients? From this image, you can see that the greatest drop in survival occurred early on in the immediate postoperative period, and then there was this slow decline in survival over time. Indeed, other studies have shown this to be true as well. These data are from a case series of 366 patients that looked at timing and causes of death in patients with heterotaxy undergoing cardiac surgery. They similarly identified that around 60% of the deaths occurred in the immediate postoperative period. Sudden cardiac death, likely due in a large part to arrhythmias, represented about 20% of deaths, cardiac non-surgical deaths 11%, and non-cardiac causes only 8%. When we dig a bit more into the perioperative mortality rates in heterotaxy patients, there's data from the Society of Thoracic Surgery database that demonstrates higher mortality rates for patients with asplenia, shown in light blue, across all preoperative STS risk categories as compared to patients without heterotaxy, that's shown in green. Polysplenia, shown in dark blue, was more of a mixed bag depending on surgical risk. And then among patients undergoing single ventricle palliation, shown over on the right, patients with heterotaxy had higher postoperative mortality after both the index shunt and the Fontana operations. These data would suggest that there's something independent of the severity of the heart disease that places patients with heterotaxy at increased risk in the postoperative period. We know that patients with asplenia appear to be a particularly high-risk group. And indeed, studies have consistently shown that patients with asplenia have higher mortality or lower survival, as shown on these curves, as compared to patients with polysplenia. You can see that the survival curves separate early on and then remain separate, suggesting again that the perioperative time period is the highest risk time for patients with asplenia. But what about asplenia makes these patients such high risk? I'll take you back to that summary that Steve showed. Recall that in asplenia, the pulmonary veins are often anomalous with or without obstruction. Atrioventricular canal defects are common and are often right or left dominant, favoring one ventricle. And there's often a single outflow tract due to pulmonary stenosis or atresia. And as a result, single ventricle heart disease is much more common in patients with asplenia than polysplenia, with most case series reporting a 2 to 3-fold higher risk of single ventricle heart disease in patients with asplenia. And it should come as no surprise to this audience that patients undergoing single ventricle palliation have worse long-term survival than those undergoing biventricular repair. So this Kaplan-Meier curve comes from the Toronto experience, where they looked at patients with left atrial isomerism in a normal heart, shown in the top curve, those with a heart suitable for biventricular repair, and those with a heart suitable for single ventricle palliation. And they found that patients with single ventricle palliation had the worst survival over the long term. What also strikes me about this graph, though, is that even among those with normal hearts, the heart yearly mortality rate was quite high, presumably due to extra cardiac disease. As a follow-up study, the Mayo group looked at their own institutional data and divided their cohort into poly versus asplenia and single versus biventricular repair. And they found that polysplenia patients with biventricular physiology had the best survival, and that asplenia with single ventricle physiology had the worst survival. Polysplenia with single ventricle heart disease was somewhere in between. And in this particular cohort, there were insufficient numbers of patients with asplenia undergoing biventricular repair to model that curve. So what about other risk factors? These data come from a cohort of approximately 260 patients followed at Boston Children's Hospital, which looked at risk factors for death over a median of 10 years. They found that the highest risk was conferred by the presence of acquired pulmonary vein stenosis after total anomalous pulmonary venous connection repair, univentricular circulation, mild or greater atrioventricular valve regurgitation, and the asplenia phenotype. And if you recall, these risk factors are also more common in right atrial isomerism, TAPVC, single ventricle physiology, and common atrioventricular canal defects, which are at increased risk of valvular regurgitation. And these same risk factors have come out time and again in other patient cohorts. The same study also performed a CART analysis, which I found particularly interesting, to look at interactions and risk factors. I like the schematic because they were able to identify that the highest risk group, shown here in red, and the lowest risk group, shown in blue, patients with the combination of a univentricular circulation and TAPVC have the highest mortality of around 71% over 10 years, compared with only 11% in patients with polysplenia and a biventricular circulation. But what about other risk factors aside from structural heart disease? Increasingly, heterotaxy is being recognized as a form of ciliopathy and often co-occurs with primary ciliary dyskinesia. This study looked at respiratory complications in patients with heterotaxy with and without ciliary dyskinesia who were undergoing cardiac surgery. And they found that patients with heterotaxy were more likely to experience respiratory complications, defined as things like failed extubations, respiratory failure, respiratory infections. They were more likely to have respiratory complications and to require inhaled beta agonists after surgery. Studies looking at infectious risks after surgery found that patients with heterotaxy have a higher long-term risk of community-acquired severe bacterial infections, but not nosocomial infections, as compared to other patients with complex congenital heart disease. So the study on the left compared community-acquired SBIs in patients with heterotaxy to those with complex congenital heart disease, but no heterotaxy, and found that the 2-year cumulative SBI rate in heterotaxy was almost 10% in patients with heterotaxy, compared to basically 0 in complex congenital heart disease. The graph on the right comes from a separate analysis of the same cohort, which examined nosocomial infections after cardiac surgery and found a comparable infection rate in both patients with congenital heart disease with and without heterotaxy. The most common causal pathogens in both groups were coag-negative staph, enterococcus, and gram-negatives. We also know that patients with heterotaxy are at high risk of arrhythmias, which may explain the high rate of sudden cardiac death in these patients. In this study, about 35% of patients with right isomerism and 51% of patients with left isomerism had arrhythmias by age 20. The most common arrhythmia in right isomerism was SVT, whereas in patients with left isomerism, it was paced bradycardia, either due to sinus node dysfunction or atrioventricular block. And we'll talk more about this in a bit. And then finally, some may ask about heart transplantation outcomes in this population. These data come from the UNOS database, in which the authors looked at waitlist duration and graft survival by indication. So the analysis included 140 patients with heterotaxy who underwent cardiac transplantation and compared outcomes to patients with congenital heart disease, but no heterotaxy, and those with cardiomyopathy as the primary indication. Median time on the waitlist for heart transplant was significantly longer, about 91 days for heterotaxy compared to 63 days for congenital heart disease and 56 for cardiomyopathy. And while early outcomes were similar, the 5-year graft survival after heart transplant was lowest in patients with heterotaxy, 69% versus 78% in congenital heart disease and 87% in cardiomyopathy.
So to wrap things up, we wanted to spend a few minutes discussing 2 fascinating high-risk cardiovascular complications that occur in heterotaxy syndrome. Here is a selection of pulmonary angiograms of patients in the Glenn stage of single ventricle fibrillation. And the question here is, can you pick out the patients just from looking at these pictures with interrupted IVC and left isomerism? Well, even without an echocardiogram, it's a good bet that these are your left isomerism patients, because they tend to get the worst of pulmonary AVMs during the Glenn stage. So we know that among patients with single ventricle congenital heart disease, those in the Glenn stage are at clear risk of pulmonary AV development. Clinically, they present with progressive and severe desaturation. Angiographically, we can pick up on the severity of pulmonary AV shunting using the pulmonary capillary transit time. When you compare the transit times of a bunch of Glenn patients, the ones with the most drastic pulmonary AVM are invariably those with interrupted IVC and left isomerism, seen on the bottom right, compared to the angiogram on the top right, which is a patient that does normal Gardner single ventricle ectoplasty. This has been reported multiple times over the years, including these nice studies showing freedom from pulmonary AVMs with a Kawashima, with the vast majority of patients developing pulmonary AVMs by age 8 to 10. As such, there has been a push to perform earlier Fontaine completions in all patients who undergo Kawashima operations in order to hopefully avoid the long-term complications associated with these severe AVMs, which dramatically increase morbidity and mortality.
But what about conduction system abnormalities? If we return to this table showing the distribution of arrhythmia types and different subtypes of isomerism, recall that SVT was the predominant rhythm abnormality in right atrial isomerism, and bradycardia, either due to sinus node dysfunction or AV block, was the most common in left atrial isomerism. But why is this the case? In general, and there are always exceptions to the rules, patients with right atrial isomerism tend to have duplicated sinus nodes or AV nodes because the atria are often mirror images of the right atrium. This redundancy in sinus and AV nodal tissue can lead to a propensity for supraventricular tachycardias, including twin AV node tachycardia. In contrast, those with left atrial isomerism have mirror image left atria, and therefore often lack normal sinus and or AV nodal tissue, leading to a propensity for sinus node dysfunction and or AV block. The data on the right are from a remarkable autopsy study from 2012, where they looked at the presence of sinus and AV nodal tissue in patients with heterotaxy. In right atrial isomerism, they found bilateral sinus nodes in over half of the cases. In left atrial isomerism, 8 out of 8 cases had no sinus node in their right atrium because it was not a right atrium, rather a morphologic left atrium. 5 of the 8 had normal sinus node architecture, but located in the left-sided atrium, and the remaining 3 had either absent or hypoplastic sinus nodes. As a result, it's not surprising that the most common arrhythmia in right atrial isomerism is SVT, either due to an ectopic atrial focus or twin AV node tachycardia. The EKG on the right shows the transition between 2 automatic foci in the atria that have different P-wave morphologies and are competing with each other for dominance. You can see the downward deflection of the P-wave in atrial rhythm 1, which transitions to an upward deflection in atrial rhythm 2 because there are 2 separate foci originating from 2 different parts of the atria. And just like different P-wave morphologies, you can also get 2 discrete QRS morphologies when there are twin AV nodes present. Depending on where the initial stimulus arises, one of the 2 AV nodes will be activated and the resultant QRS complex will be generated on the surface EKG. And with the presence of 2 AV nodes, the risk of creating a reentrant circuit between those nodes is quite high, leading to AV nodal reentrant tachycardia. Hence, patients with right atrial isomerism are at increased risk for fast arrhythmias due to duplication of the conduction system and the potential for reentrant circuits. But what about left atrial isomerism? Again, in left atrial isomerism, the sinus node can be normal, present in a different location, absent, or hypoplastic. So the rhythm strip on the right shows a normal sinus P wave on the top and an ectopic P wave coming from a different part of the atrium on the bottom. You'll immediately know that the ectopic rhythm is slow because the foci isn't, or the focus isn't coming from the sinus node, and the P wave is inverted in lead 2. And finally, because patients with left atrial isomerism can have abnormalities in the structure of the AV node, they are at high risk for the development of complete heart block. On the EKG on the right, you can see complete dissociation of P waves representing atrial contraction and QRS complexes representing ventricular contraction. High-grade AV block can present in utero or later on in life. And actually, in one study, a third of fetuses with left atrial isomerism had complete heart block in utero, and it was the leading cause of mortality prenatally. So many of these patients will go on to require pacemakers. So I hope from our talk today, we've been able to convince you that complex congenital heart disease is quite common in heterotaxy. Current classification systems, including right atrial and left atrial isomerism or asplenia, polysplenia, are incomplete. Heterotaxy patients are at high risk of death and cardiac complications, both postoperatively and over the long term. And there are unique features of the cardiac anatomy that predispose patients